Ahmed, we only have like a couple of minutes, right? أنت muted.
هبدأ إن شاء الله دكتور أسامة في خلال دقيقتين بالظبط إن شاء الله.
Okay, when you start, I'll mute myself, then I'll unmute, and then I'll share my screen. Okay.
Okay, no problem.
You have a good number of attendees so far.
Yes.
Okay. And I send you the short bio that you have it, right?
Yeah, I have it already.
Okay, that's fine. So we'll start within a minute. I'm going to mute myself.
Okay. Good evening and welcome to our first webinar about vitamin D sponsored by Euro-Pharm. I see a good number of attendees and I know the topic is very interesting, but I think the lockdown also helped to see more doctors. First, I want to thank each healthcare professional and each pharmacist for going to your duty and facing risk every day and every time you go to work. I believe the critical situation made the world to understand who is the real superhero is. Today, we have a very interesting topic about COVID-19 and vitamin D. Is it really work? That's what we'll know after a while. But allow me first to share with you a short presentation about Euro-Pharm, an expert company in vitamin D products. So I do believe that most of you know about Euro-Pharm and you know about Euro-D and D40 and BDVD. And today I came to share with you also about the success and about the company who is pioneer and expert in the production and manufacturing of vitamin D with a wide range of products that you are using on a daily basis. So Euro-Pharm started in Canada in 1996, and the company is growing rapidly and it's based in Montreal, and we are actually specialized mainly in vitamin D. And also we have some acute medication like analgesic, like painkiller, and like laxative products. And in a very short span of time, we moved to the international market and we started in UAE in 2005. And we entered the market to identify there is a clear gap in vitamin D at that point of time, as the awareness of vitamin D was low at 2005. And because we are a very regular supplier and we are providing a high quality product, so we are the leading supplier in the private market and in the government sector for vitamin D. You can see vitamin D from Euro-Pharm like BDVD and D40 and Euro-D. You can see it in every private hospital. You can see it in every government hospital, starting from the Ministry of Health to SIHA to DHA. And we started in 2005 actually by launching the BDVD 400 international unit. And when we go to talk to neonatologists and for pediatrician about BDVD 400 international unit, at that point of time, it was like very strange and it's like a very high dose. Today we are talking about that BDVD is like a protocol for every neonate to take a 400 international unit of vitamin D on a daily basis. And when we provide BDVD, it comes as a unique micellized form. So it is not an oily based form. And you can imagine there is a clear difference between a baby who is taking a water and baby who is taking oil. It's quite difficult for them to take oil. But as a micellized form, it's make a more convenient for babies. And on the other hand, also it's confirmed to be better on the level of absorption. And that's what published in Journal of Pediatric Endocrinology and Metabolism 2006, that the methylized form in the school children was better in the absorption in comparison to the fat-soluble form. You can see here that 100% of the children was able to achieve the target level of vitamin D in this study, in comparison with 83% only in the oil-based form. And for that conclusion, it showed that the methylized vitamin D is better in the absorption in comparison to the fat-soluble vitamin. Then we moved to the other formula like Euro-D 10,000 and like D4 50,000 with a soft gelatinous capsule, and which is the absorption in comparison to the hard tablet form. And as you can see here, that it's a quite small tablet size. Sorry, it's a quite small capsule size. You can see this is the real size of the capsule of Euro-D, and this is the size of the capsule of the D4. So the easiest way and the most convenient way for any adult to take a vitamin D is straight ahead to take one capsule of soft gelatinous capsule of Euro-D and D4. And this is by far better than taking a hard tablet, because the vitamin itself, it's oil-based in nature. So making it in a tablet form, it makes it even difficult for absorption. And I would like to share with you a video which shows the big difference between the tablet form and between the oil-based form. So as you can see, there is a clear and big difference between the tablet form and the soft gelatinous capsule form. And even before I joined Euro-Pharm, I was always asking how a company over 15 years till now, she considered as a leading supplier of vitamin D. But I believe that looking always for providing a high quality brand is our commitment toward a healthy society. Thank you very much. I finished my presentation, and now we will move to the most important part of the meeting today. I would like also to welcome Dr. Osama Barakat, who will talk today about, is it really worth to give a vitamin D for a COVID-19 patient, and to what extent vitamin D is important. Dr. Osama is a speaker who you enjoy every minute while you are listening to him. As a short information about Dr. Osama is graduated from the Royal Free Hospital Medical School, University of London in 1999, and he underwent his internal medicine training at the University of Norfolk and Norwich Hospital, where he obtained his MRCP in 2002. He took a post as a research fellow between 2002 and 2004 to study the prevalence and incidence of diabetic eye disease in population of East Anglia, leading to his master's degree. He obtained certificate of completion of specialist training in diabetes endocrinology and general internal medicine in 2008 at the Cambridge Deanery, and his current post is a consultant physician, diabetologist, and endocrinologist in Imperial College London in Abu Dhabi. So the floor is yours now, Dr. Osama. You are most welcome.
Good evening, everyone, and thank you, Ahmed, for the very nice introduction. I would like to thank everybody who took the time to be with us. I can see a good number of attendees here, which makes me pleased. I would like to thank Euro-Pharm for organizing this, what I would hope to be educational event, and anybody even in IT who stood behind this event. Really, what we're trying to do tonight is not to promote for any form of vitamin D. If anything, we're trying to talk a little bit about some information that we probably know about vitamin D, but we're still kind of not grabbing the fact that vitamin D is very important for us. So we'll go a little bit in which I hate a lot, is physiology and of vitamin D. I always find it difficult to understand and raise physiology. And then we'll talk a little bit about, source of vitamin D, then vitamin D deficiency, and how do we kind of prevent and treat vitamin D, evidence behind vitamin D immunity, and some articles, meta-analysis supporting our view in regards to vitamin D and COVID-19. Then we'll conclude with a few information. Then you can drop your questions in the chat box, and Dr. Ahmed will help me through the questions later. Now, vitamin D physiology, I try to simplify it for myself, so at least I can understand it when I transmit those information to you. We get majority of our vitamin D really from sunlight. Now, we have some elements in the food, but not enough probably to compensate what the sunlight and UVB light and skin exposure gives us in general. So in simple terms, sun exposure that normally activate our deactive component under the skin, which is 7-dehydroxy cholesterol, and then this turn into vitamin D3, which is not the actually active component. But for you to get an active component, D3 has to go through two process of hydroxylation in the liver and the kidney. Then eventually you get the component of the most active one, which is 125 hydroxy vitamin D3, which normally allows us to absorb more calcium into the gut and drop more calcium into the bone, and so on. So really, unless you're taking pure supplement, it's very difficult to get your vitamin D requirement, just by food, and therefore sun exposure and supplements, as we'll show you later, are probably the most important factor when it comes to vitamin D levels in our circulation. Now, and unfortunately, if you actually go back to the early time of the Industrial Revolution in the US and Europe, kids look like this completely. That's simply because people were struck with a new form of industrial revolution and started to go more into manufacturers inside the houses, and kids were playing in little alleyways, and nobody actually knew what's happened till rickets was recognized, and then those kids were getting slightly better by a bit of sun exposure and cod liver oil. But actually, you can all imagine that we moved from this and we became into the digital age, and we become into the, confined into the computer present. All of us now, forget about COVID-19 and the lockdown, majority of us now not being exposed enough to the sunlight, and therefore we're all sitting behind our laptops, our kids are sitting behind their iPads and PCs and computer games. So we certainly become a population of vitamin D deficient population. Certainly rickets has come down in number, but vitamin D deficiency hasn't really been fully treated. Now, big debate is, where is the enough and sufficient vitamin D levels that we should stand at? And this is those are two categories, one from the American Association of Clinical Endocrinologists and one from the Endocrine Society. And you can see for yourself the level of deficiency or severe deficiency up to the sufficient level. If you ask me as an endocrinologist, and I'm not a vitamin D expert, I think majority of endocrinologists will accept a 40 nanogram to 60 nanogram per ml as a sufficient amount of vitamin D, because that's the level when you actually don't irritate your parathyroid. Because once your vitamin D level falls down, then your parathyroid has to trigger to produce PTH and then to try and get more calcium. And we know from human observation that people who work in the farms, are outside in the sun working all the time, they generally have a level between 40 to 60 nanogram per ml without any vitamin D supplementation. So 40 to 60 nanogram per ml is what we say acceptable, unless there are other metabolic disorders that require higher amount of vitamin D. Now, we all know that people who are most prone to vitamin D deficiency are infant and kids, because they just newborn, not exposed to sunlight, pregnant ladies who breastfeeding, particularly teenagers and young women, which we see a lot of them in the UK and northern part of Europe, elderly population above 65. But those are really the one who, if you look at the COVID-19 pandemic, were hit by the highest death rate. Type 2 diabetic, obese people, people with cardiovascular disease, hypertension, and chronic lung disease. So people with chronic diseases that probably limited their mobility. In addition to this, those people are actually on a lot of medication, and therefore probably vitamin D supplementation comes least at the priority of the physician treating those people. And certainly people who have no sun exposure and so on. But I will really concentrate today on people with diabetes, obesity, and chronic diseases are the one probably the most vitamin D deficient in certain population, as we can see later, as we will see later. So those are the Endocrine Society and American Academy of Pediatrics recommendations. So we'll go through prevention and treatment of vitamin D deficiencies. If we start with the children in terms of prevention, what you need for for a child below the age of 1 year is you need around 400 units a day, and you may require 1,000 international units a day to maintain an optimal level of serum vitamin D. Children and adolescents age 1 to 18, again, you need anything between 600 international units per day up to 1,000 to maintain your level. That's just we talk in prevention. If you to treat those groups, so again, for kids below the age of 1, you really need a large amount for children. So you need around 2,000 international units per day for vitamin D for at least 6 to 12 weeks sometimes to achieve a level above 30 nanogram per ml, which is probably recommended for this age group. And if you go older, between 1 to 18 years old, to treat vitamin D deficiency, again, you will require 2,000 units for at least 6 weeks, and then you may have to maintain this with anything between 600 to 100,000. So you go from when you treat for 6 weeks, and you go back to the prevention and you maintain it for a long time. In terms of adults above the age of 18, our requirement for prevention, I would say probably anything between 1,500 to 2,000, that's probably acceptable amount. But when it comes to treatment, if you are vitamin D deficient as an adult, you will need 6,000 or maybe per day, which comes up to 50,000 per week. This is why people say, why 10,000 vitamin D, why 50,000? It also do with the requirement. And you need to be treating adults for at least, as I said to you, from my experience, for 3 months before they can achieve a level. Then you go back into the prevention, which is around 1,500 to 2,000 per day, which means if you're gonna treat someone, an adult with 50,000 for 3 months, and then you wanna down-regulate and maintain them, they will probably need around 14 to 15,000 units of vitamin D per week. Because if you think they need 2,000 per day, multiply this by 7, comes to 17,000. And the majority of the time, once we've treated with 50,000, we go and maintain those people on 10,000 per week, in addition to sometimes daily supplement. What's about obese and people with malabsorption? Those are people who require higher doses of, or if you look at just prevention, those people require anything between 3,000 to 6,000 international units per day, a large amount, that just to keep the level just above 30 nanogram per ml. So you haven't even reached the 40 or 60. And once they become deficient, then you need to be treating them between 6,000 to 10,000 international units per day. It's a lot of vitamin D. and you need to be treating them again for probably, I would say, anything between 8 to 12 weeks. Then you go back again to maintenance dose, which is around 3,000 to 6,000 international per day, which is probably equivalent to 20,000 per week. So if you can imagine, it's a lot of vitamin D. Now, pregnancy, this is a big debate because we're supposed not to overload our pregnant ladies with vitamin D. Most recent evidence now suggests that probably giving vitamin D from 24 weeks onwards have a beneficial effect on both the outcome and well-being of the mother and the baby. But in general, all pregnant ladies require what the infant needs, 400 international per day. But if you have high-risk pregnant women, then you go up probably to the adolescent dose of 1,000 per day. And during lactation, we do recommend they take 1 tablet of vitamin D of 1,000 per day to get into enough level of vitamin D in the body. And if you have somebody in pregnancy who is really vitamin D deficient, then you probably treat them for 4 weeks, 4 to 6 weeks, either with the 20,000 per week or 10,000 twice a week. You can do this probably for 4 to 6 weeks. Once you reach a satisfactory level, then you can just keep them on maintenance dose. So you can see how things change between prevention, respiratory into treatment. But generally speaking, we need a lot of vitamin D once we become deficient, and we only need a touch of daily doses or weekly doses to keep us safe. So we probably shouldn't be waiting to become deficient before we can initiate vitamin D. For all the ladies with postmenopausal women, those are the people who are really at risk of osteoporosis, we recommend around probably 800 international per day. And I think that's probably too little, it depends on the age. But I would say probably 1,500 is what I would say acceptable. And once they become deficient, then you go back exactly to the adolescent dose, the adult dose of around 50,000 per week. Then you wean that one once you've reached 30 nanogram per mil, and you maintain this with probably 2,000 per day, which is roughly around 20,000 per week. So a lot of vitamin D, and therefore we shouldn't be needing to be deficient to be having a large amount of vitamin D. I think majority of our endocrinologists nowadays probably will refrain from the measurement, and they just, people at risk, they stick them into 20,000 per week. I would say somebody who needs 3,000 per day, then they would need 21,000 per week, then put them on 20,000 per week for the rest of the year, especially if they're high risk and they're not sun exposed and they live in certain area where winter times are longer than summer times. And for add-on treatment osteoporosis, again, you require the same thing for around 800 units per day for people who are at risk of vitamin D deficiency. So we've talked a little bit about how to get vitamin D from the sunlight, and where the active metabolite is, and where can we get our vitamin D from certain foods and so on. Then we've been through the rickets problem that was shown early in the 1920s in Europe and America, where the revolution in industry has taken place, and people were stuck into different places with no sun exposure. And even us now in 2020, we're still stuck behind our laptops and our digital age. So are there any evidence really about vitamin D role in immunity? Okay, well, we know from in vitro evidence that vitamin D is involved in immune cell response to some viral and bacterial respiratory pathogenesis. Look, we know from the past that vitamin D probably plays an important role in treating tuberculosis, bacterial vaginosis, and influenza. We've known this for a while, and you really have to remember that vitamin D receptor, it exists on every cell surface. It doesn't just exist on your bone cells. Vitamin D receptor, it's everywhere. And vitamin D receptor has the ability to upregulate your immune protein, which eventually is responsible for probably over 2,000 gene expression. So there must be a role for vitamin D in immunity and fighting infection. And we've known for a while, and we'll show you some studies, that probably if you have low vitamin D, then you probably unable to suppress the interleukin-6 and cytokine formation, which eventually may lead to poor immunity and poor outcome. But that's what we know in vitro. 1900, people knew that putting patients with tuberculosis out in the sun, that's in the 1900s, was actually good for them. So stick these people out in the sun, let them be sun exposed, and they will get better. And even evolving evidence in tuberculosis treatment has shown that there's some benefit in terms of vitamin D supplementation for people with tuberculosis. So this is kind of known fact. Okay, so where does the idea come from that vitamin D is helpful in respiratory tract infection? And this is a lovely meta-analysis published in 2019. Really, this is one of the most interesting analyses that I've seen. It consists of a number of trials with over 78,000 patients. What they're trying to look at in this meta-analysis is, does low vitamin D concentration increase your risk of upper respiratory tract infection? Simple as this. And if you have enough vitamin D, are you less likely to get it? Look what they found. So if you look at the forest plot and to the left, you can see that that's the trials and that's the results on the right. You can see that patients on those meta-analyses who did have sufficient vitamin D level were actually less likely to get an ARTI, an upper respiratory tract infection. So there's a role in actually for vitamin D in reducing your respiratory tract infection. Now it may not be a causality, but certainly there's a correlation between the level of vitamin D and incidence of upper respiratory tract infection. What they also found, for a certain drop in vitamin D, around 10 nanomol per liter, or if you want to do it in nanogram, that actually for each 10 nanomol drop, you're increasing your risk of getting an upper respiratory tract infection. So not only if you're deficient, but if you actually keep dropping, then your risk is higher, which is actually very interesting when you analyze it. Another meta-analysis that's published back in 2013, they were looking at that, does supplementation taken, vitamin D supplementation taken over weeks to months, does that promote a better outcome when you have upper respiratory tract infection? So if you're a vitamin D deficient and we supplement you over weeks or months, whatever the treatment recommendation is, does that actually prevent you from getting lower incidence of ARTIs? So what they found when vitamin D3 was given daily, it was associated with significant reduction in ARTIs. Whereas giving vitamin D3 had no effect when it was given in large bolus doses. Now, my old professor and teacher, Professor Greenwood, used to tell me that giving vitamin D in large boluses is like going to the school once a month. And if you give it every day, that's like you going to the school every day and you're learning something new every day. So what they found from this meta-analysis, that actually there's efficacy for giving daily vitamin D over a period of weeks or months over boluses. So if you were given daily vitamin D, then you are actually less likely to get a respiratory tract infection. So here you can see the first meta-analysis showed that level of vitamin D is protective. Further drop, like 10 nanomole per ml, is actually negatively correlated with the incidence of ARTIs. And in this meta-analysis in 2013, they found that actually giving daily vitamin D over weeks or months, depending on the protocol needed to reach this factor level, was actually beneficial versus giving boluses. Giving larger amount in boluses did not actually protect you from, or was not actually correlated with a lower incidence of ARTI. So you can see where the evidence is coming from. Another meta-analysis was looking at, does vitamin D supplementation resulted in reduction in proportion of patients experiencing at least one ARTI? So here what they were looking for, daily or weekly dosing of vitamin D versus intermittent large doses, as we just talked before. Are there any differences? So if you give daily or weekly, so the appropriate, as we shown you before the recommendation from the Endocrine Society. If we give you enough daily dose of 6,000 or 50,000 per week versus giving boluses of like, over 30,000 international units in one go each month, are there any differences in acquiring or requiring an ARTI? And look at the evidence. That's a two-step individual participation data meta-analysis. Look at the first plot here. To the left, daily and weekly appropriate dosing of vitamin D resulted in lower incidence of ARTI versus the group that has large boluses. So here we've shown you 3 meta-analyses that actually support that low level is negatively correlated with ARTI incidence. Further drop results even in worse outcome. Maintenance over weeks or month, appropriate maintenance, resulted in better outcome. And daily and weekly doses were much better than a monthly boluses. Okay, so having seen the facts from those meta-analyses, should we consider vitamin D in COVID-19? You all know about coronavirus. I'm not here to lecture about coronavirus, but just an overview that, coronaviruses are groups of viruses that we've had before, and SARS-CoV-2 is the 7th of its brother. Some of these viruses have very mild symptoms, but we've had SARS and MERS before, and we know that SARS-CoV-2, which is a beta virus, is the cause behind COVID-19 respiratory distress syndrome, which was first discovered in December in the city of Wuhan in China, discovered in the winter. And then some evidence say, some probably publications say that it exists in November and December, which means probably, it's all in the winter. So now, before we talk about coronavirus specific, if you actually think of any viruses in general, majority of those viruses have a seasonal relation. We know that viruses appear more likely most likely they appear in the winter. But what was striking about coronavirus distribution, as we'll show you before, so the outbreaks had some correlation at the latitude line in the current winter hemisphere. In addition to this, vitamin D deficiency, we know it happens in the winter. So here we have a virus with seasonality related to winter. We have higher incidence depending on the latitude line in the current winter hemisphere. We know for sure that vitamin D deficiency occurs more in the winter because we have less sunlight. And Italy, which has probably the worst vitamin D deficiency rate in Europe, was hit hard by coronavirus. And if you want to argue about Japan being the outlier in the north, well, it's interesting to know that vitamin D deficiency in elderly population in Japan, who are active elderly, is actually below 5%. In addition to this, we know the Japanese diet is full of high fish content diet. So Japan, yes, is a northern part of the hemisphere, but at the same time, prevalence of vitamin D deficiency in Japan, even in active elderly, is below 5%. It's phenomenal. In addition to the high vitamin D diet because of the amount of fish they eat in Japan. So let's look at the latitude. So this is the death latitude with the population by latitude shows a striking northern hemisphere bias. So if you plot the COVID-19 death by latitude, and that's from 22nd of March 2020, and overlying with the population reveals a striking northern winter hemisphere bias above the 20-degree latitude line and the severity of the outbreaks. We're actually in tropical, and people were asking why it's not that severe in South America. So tropical latitude and southern hemisphere location, the outbreak were very mild. And case fatality rates in lower latitude have been very low relative to the northern location. So it's to do with the latitude, the winter hemisphere, and the vitamin D deficiency that happens in the winter. And this is very interesting, comprehensive screening that happens in Scotland between June 2006 and June 2009, And what they're really doing, that's using 11,000 patients, just doing diagnostic respiratory samples using PCR. They found that coronaviruses, because we knew about coronaviruses before, right? Within the COVID-19, it just appeared now, but we know about coronavirus from before. That coronaviruses display marked winter seasonality between the month of December and April. But they deducted nothing in the summer. That's even in Scotland, which is supposed to be a very cold country with little sunshine. So the highest level of coronavirus is detected in between 2006 and 2009 in Scotland was actually between the month of December and April. A very nice paper written to the BMJ by Professor Andrea Costina, and really talking about Italy and why this has happened. And it's obvious that from his note that actually the northern part of Italy was hit hard by coronavirus, simply because of the age of population there, more women, and higher incidence of vitamin D deficiency. If you look at the numbers, if you compare them with Japan, 76% of women in that area have a vitamin D below 12 nanogram per mil. And 27% of them had a vitamin D level as low as 5 nanogram per mil. So striking differences in roughly the same region between different countries, related actually maybe to diet and vitamin D. If you look at Japan in particular, Japan's recovery rate was 7 times higher than death. So for each one death, there are probably 7 cases of recovery, where in other places, northern territories, it was actually 1-to-1 ratio. And as I explained to you before, that's simply because the prevalence of vitamin E deficiency in Japan is very minimal, below 5% in active elderly, in addition to the diet, plus maybe the difference between the social culture in Italy and Japan, where social distancing is more actually respected in Japan, where the social culture in Italy of gathering and hugging and saluting each other is slightly different. But certainly, those are just cultural differences and should not lead to the high incidence of death and less incidence of recovery. It's probably to do with the population, the age, and vitamin D, and the background of the chronic diseases existed in this population. A lot of interesting mechanism about transmitting SARS-CoV-2 in relation of the ARDS. We know, and we started to know, that SARS-CoV-2 virus enters the cells, especially the respiratory cells, via ACE2 receptor. So that creates an imbalance in the steady state cytokine regulatory axis involving the RAS and IP10 leads to cytokine storm, which in the host, which is the human being, which actually probably causing the ARDS and the higher cause of fatality. And I'm sure you've seen these graphs in many talks about COVID-19 recently, but this is particularly in diabetics. This ACE2 links diabetes mellitus, hypertension, and cardiovascular disease to COVID-19. A lot of diabetics take ACE inhibitor and ARBs, but the recommendation is very strong. You have to differentiate that we have 2 different ACE receptors in our body. We have extracellular and intracellular. So you have to differentiate between the one that acts by transmitting the virus and the one that works by blocking the RAS system. But certainly, this is one of the main mechanisms how SARS-CoV-2 has been transmitted with a spike protein binding to the ACE2, which eventually leads to interleukin-6 dominated cytokine storm, which I mentioned to you, is the reason why people got into RDS. And we've witnessed this most in diabetics and people with hypertension, simply because majority of them do take ACE inhibitor. We don't know, but it may be majority of those people with diabetes, hypertension, and cardiovascular disease are actually vitamin D deficient. So is there a way that vitamin D might play a role in suppressing this bad circuit? So this is a nice publication in 2002, and that really shows that there's an upregulation of the chemokine ligand 2 via a severe ARDS spike ACE2 signaling pathway. So it's possible that the high fatality rate of SARS results from the severe immune response caused by the cytokine and the chemokine because of the way the virus has been transmitted. And we know somehow that actually vitamin D itself, and particularly vitamin D receptor, which exists on T cell and B cell and even on epithelial cell, does produce two immune proteins, which is the cathelicidins and defensins. And those cathelicidins and defensins do reduce interleukin-6 and tumor necrosis factor, which in turn will actually result in reduction of the cytokine storm. So it's two sides of the coin. So what is the relation between vitamin D, actually biochemistry, the RAS system, and the ARDS? And here we've summarized for you probably 7 possibilities. So number 1, we knew from before that chronic and prolonged vitamin D deficiency will induce lung fibrosis. And what we have witnessed in recovered COVID-19 patients, the fast decline in the lung function test, and around 20 to 30%. And actually, some of these patients have been left with some lung fibrosis. The second possibility is vitamin D deficiency contributes directly to the ARDS, as I will show you later. And people who spend longer time on mechanical ventilation were found to have the least level of vitamin D. Around 90% of these people who spend long time on mechanical ventilation were actually vitamin D deficient. In addition, we knew that vitamin D alleviates the lipopolysaccharide-induced acute lung injury via regulation of the RAS system. And as I mentioned to you before, that vitamin D receptor attenuates acute lung injury by blocking the angiotensin 2 type 2 pathway and the RAS system. And it's possible that the active form 125 dehydroxyvitamin D3 suppresses the renin gene transcription by blocking the activity of the cyclic AMP or CAMP response element in the renin gene promoter. And eventually, we know that vitamin D supplementation is safe and does protect against respiratory infection. We've shown you this in meta-analysis. So this is a first paper in 2017 talking about vitamin D deficiency and fibrosis. What that study shows that actually demonstrates that chronic and prolonged vitamin D deficiency may induce the RAS activation, which eventually will stimulate the expression of the pro-fibrotic factors and activate fibrotic cascade, which lead to fibrosis. And I mentioned to you before that in some COVID patients, lung function has declined by 20 to 30% after recovery, and we have seen some publication about a leftover pulmonary fibrosis despite a very short duration of the disease, but actually the quick decline in lung function test and probably the expression of the pro-fibrotic factor, which eventually activate the fibrotic cascade. Another paper in thorax in 2015, and that's really a relation between does vitamin D deficiency directly augment the acute respiratory syndrome appearances, and they conclude that vitamin D deficiency is common in people who have ARDS, and the deficiency of vitamin D appears to contribute to the development of the ARDS, and approaches to correct it in patients at risk of ARDS should be developed. That's recommendation in thorax in 2015. And what they notice in this paper, if you look to the left of the slide, that people with ARDS had the lower vitamin D level. People at risk had slightly better vitamin D, but healthy controlled who got affected had sufficient vitamin D. And if you look at the mortality outcome, it's people who died versus the people who survived ICU admission. You found people who died had the lowest concentration of vitamin D versus the people who survived with a slightly higher vitamin D level. So there must be a direct correlation between the severity of ARDS and the vitamin D level. What we also know that low vitamin D status occurs in 90% of patients with ARDS, and is associated with the longer duration of mechanical ventilation. So people who spend, this is a paper from Critical Care, people who spend longer time on the ventilator were actually 9 out of 10 were vitamin D deficient before they got admitted. So you see that the correlation between the vitamin D level and the status of severity of ARDS, and relation between vitamin D and fibrosis. Now, probably the most important bit, and this is again a paper published a couple of 3 years ago, that vitamin D alleviates lipopolysaccharide-induced lung injury via the regulation of the RAS system. So it's actually established that vitamin D exhibits an anti-inflammatory. I've told you that vitamin D receptor does induce immune protein like defenses and calcificins, and those in turn will lower your interleukin-6 and tumor necrosis factor. However, the specific effect on vitamin D and acute lung injury remains probably largely unknown. So the aim from this study was to investigate whether and which mechanism vitamin D alleviate the lipopolysaccharide-induced acute lung injury. Another paper talks about the vitamin D receptors and the attenuation of acute lung injury by blocking the angiotensin II type 2 pathway and renin-angiotensin system. So certainly, as we can see once again, there's a relation between vitamin D level and RAS system and ARDS, vitamin D level and promotion of the fibroblastic elements that leads to lung fibrosis. And here we have and there's definitely a relation between vitamin D deficiency and the severity of acute lung injury. But here, this observation provided evidence that vitamin D receptor signaling prevents lung injury by blocking the angiotensin II type 2 MLC kinase cascade and the RAS system. So in any way you look at vitamin D versus acute lung injury, you will find benefit in terms of levels, supplementation, and the vitamin D receptors that present on every cell in our body. And what they also noted from another publication, actually an old publication, 2007, looking at the active 1,25-dihydroxyvitamin D3 does actually suppress the renin-gene transcription by blocking the activity of the cyclic AMP response element in the renin gene promoters. You have to think of VDR, vitamin D receptor, as a probably nuclear transcription factor that involved in the expression of probably, 2,000 genes. So it's epigenetic at work. So what they've shown in this trial, they indicate that the 125 dihydroxyvitamin D suppresses the renin gene expression, at least in part by blocking the formation of CRE and CRB CBP complex, which is responsible for the severity of the ARDS and death and fatality in viral upper respiratory tract infection, and particularly in viruses like COVID-19. So is it safe to give vitamin D supplementation in order to prevent acute respiratory tract infection? That's another systemic review published in February 2017 in the BMJ, and that shows actually that vitamin D supplementation was very safe, and it's actually protective against ARTI. A patient actually with very vitamin D deficient are those the people not receiving bolus doses got the most benefit. So if you're vitamin D deficient and you were given daily supplementation or properly weekly supplementation, not boluses, in the presence of ARTI, then you're actually more likely to either prevent the ARTI or at least reduce the severity. So overdosing of vitamin D is not at all recommended. So the safest way to do it is either by daily or weekly appropriate dose according to the recommendation and the target you want to reach. And you can see from this meta-analysis, there's actually to the left where people who are actually vitamin D deficient. So it shows the negative correlation that if you're vitamin D deficient, then you're more likely to get more ARTI, and to the right, if you actually have sufficient vitamin D level, then you're actually less likely to experience an ARTI infection. And if you do experience it, then the severity will be reduced by the sufficient amount of vitamin D. So, in conclusion, there's some evidence that vitamin D may have a role in preventing other respiratory tract infections, particularly for people with low or very low vitamin D. Whereas these evidence comes from systemic review of randomized trials, that we have seen that people at risk of vitamin D deficiency should in any case take supplementation in line with their current guidelines, local guidelines or the international guidelines. Currently in our area, population UAE is actually advised to take supplements. Similarly, even clinicians should continue to treat people with vitamin D. As we do in telemedicine nowadays, actually automatically, if somebody had a sufficient vitamin D level, say 3 months ago, I just supplement them with 10,000 per week. And if somebody had a borderline between 40 to say 50 nanogram per mil, I give them 50,000 every other week, or 25,000 per week. And people who are actually very deficient or severely deficient 3 months ago, even with no recent blood test, I will give them 50,000 per week for 3 months. This evidence strongly suggests that vitamin D supplement could be effective in preventing COVID-19 and play a key role in treating patients if added to existing treatment plan, specifically if this is done early and in appropriate fashion and manner. So to reduce the risk of infection, it's recommended people at risk of influenza, like your type 2 diabetic, elderly, asthma, COPD, people with cardiovascular disease, hypertension, heart failure, they should consider a 10,000 international per day of vitamin D at least for a few weeks to rapidly rise their concentration. Then you can follow this by 5,000 per day. And really the aim is to get above 40 to 60 nanogram per mil or 100 to 150 nanomole. Because the patient says, doctor, you told me my vitamin D is only 75. Last week it was 60 and they told me it's okay. Well, you have to differentiate, explain to the patient this difference between nanogram per mil and nanomole per mil, because it depends on the commercial kit being used. We should be encouraged to, regardless of COVID-19, we should not, and we're not posing our population, but we should sufficiently replace vitamin D level. Otherwise, we should be sitting in the winter like this, exposed to sunlight all the time. Thank you very much for your time.
Thank you very much, Dr. Osama, for your presentation. I think you covered all the aspects that we are talking about related to vitamin D in general, and especially for vitamin D in the current situation of COVID-19. I received many questions, and I would like to share with you some of this question. So if you allow me. So we received a question related to what is the symptoms of vitamin D deficiency.
Okay. So vitamin D deficiency symptoms, it's very weird. People present with fatigue, dizziness, bone pain, hair loss, you name it. Vitamin D deficiency symptoms are actually very, very wide. And people don't present with fractures unless they have osteoporosis. They present with fatigue, tiredness, low mood, hair loss, vertigo-like symptoms, cramps, GI disturbances. It's actually very wide.
So Dr. Osama, we can say that there is no specific symptoms that can assure that patient has a vitamin D deficiency.
Big spectrum of symptoms.
So I believe that there is some clinical trials that showing that 9 out of 10 of the population in UAE, they having a vitamin D deficiency. And I believe in as long as the patient is not taking vitamin D before, so most probably he will be deficient. Are you agree with me in this?
Yes.
Great. So also we received another question about the single dose injection, the high dose to boost the immunity. They are talking about the 100,000 international unit of vitamin D in a one shot, or 300,000 international unit of vitamin D. So what's your opinion regarding this in immunity?
I mean, we've shown you the meta-analysis evidence that actually boluses does not protect at all. Because all we're doing, I mean, it's interesting, we've seen this in observational study in postmenopausal women with osteoporosis. If you give them high dose of vitamin D in boluses, you increase risk of fracture. because they're actually disturbing your parathyroid hormone. Okay.
Yes.
The same here. All what you get is actually you get a steep rise in vitamin D, and we've seen this even people post bariatric surgery, because they're not keen to take tablets. They don't take injections. They like it. It's just psychological thing. And if you give them vitamin D injection, all you do is it's gonna rise for a week or two. They come back after 3 months. They may be worse or similar to where they were. So they start with 30 nanogram per ml, or say, I don't know, 45 nanomole per liter, and you give them the injection. The next time is the same results. So actually, you've not protected them from anything. And remember, those bariatric surgery patients, they're at risk of osteoporosis in the first 18 months post surgery. So you really should supplement. I would, in my practice, I'm forced to do it because the patient will not take anything else.
Yeah. So another question, Dr. Osama, came, which regarding the daily dose and weekly dose, which one is better? And I think
it's the same, providing you take the recommended amount. No difference.
Great. Also, there is another question about if the food intake alone is sufficient to provide the daily requirement from vitamin D, yes or no?
No, absolutely not. You need to be taking supplement or live in Japan with vitamin D, or have, you have to have salmon every day and oily fish every day. Yes. The government in Europe and America, after the rickets crisis, they fortified the food, yeah? So there was the milk and cereal, and you have to have a large glass of orange juice or big bowl of cereal to get 1,000 international units of vitamin D. So you need 3 glasses of orange juice or 3 cereal bowls to get 3,000 international units. So food is it's an important factor in our life to eat healthy, but it's not sufficient to replace the vitamin D deficiency.
Yes. So I believe also there is an interesting question about the relation between vitamin D and depression. So if you would like to comment on this question.
I don't know much about the data, but it certainly does seem to be. It doesn't affect you cognitive at all, impairment. But we've seen it in women, postmenopausal women, who actually are vitamin D deficient. That the risk of depression is higher in them. And you have to remember back with the old data from gynecology that, and allow me to express this, dry vagina and bacterial vaginosis was very common in ladies with vitamin D deficient, which created a lot of sexual discomfort for them and depression thereon in life. Okay, so we've not seen severe depression cases, but certainly it plays a role in the mood. Okay, especially in postmenopausal women or perimenopausal women. Okay. And certainly, it does not affect your cognitive impairment at all, unlike B12 deficiency and other components. So it does not affect cognitive and does not cause severe depression, but does change your mood a little bit.
I totally understand, Dr. Osama, and if you allow me, also I saw some clinical trial with showing that the hydroxylation process is taking place in the brain. So there's a relation for a way or another with vitamin D and the depression. Of course, they found also that patient with depression has severe vitamin D deficiency. Maybe it has some work related to the anti-inflammatory effect and controls the cytokines release. And there's some information also about the serotonin regulation, but there is nothing which is confirmed 100% on the correlation between the vitamin D and the depression. And also, doctor, there is also a question about obese people. If they need a higher dose of vitamin D, which is correlated with a high level of adipose tissue. So I would like also to hear from you, what is your comment regarding this?
It's very interesting that we always thought obese people are full of vitamin D, right? Okay.
Yes.
The most malabsorbing person is an obese person. Okay. We're not going to go into obesity. I'll give you an example of my experience. Diabetic patient. Those patients will take probably 14 to 15 tablets per day. Okay.
Yes.
Once you've had diabetes for 7 to 10 years, you will have somehow a degree of gut dysmotility and some degree of gastroparesis. In addition, majority of those diabetic, I'm talking about diabetic patients we see in the gut, have either an active or an old Helicobacter infection. So the gut motility in obesity and amount of medication they take and the diabetes, in addition to the gastric reflux, makes it very difficult for them to be absorbing vitamin D properly. In addition, compliance plays a very big role in those patients taking the enough and regular medication. Majority of them are confined to home and immobile because of the obesity, back pain, so on, lack of confidence from the eye complication and postural hypertension from medication, SGLT2 urination. So their sun exposure is very little. So those are the ones you need to watch. Now, it's very well known that obese female ladies with type 2 diabetes are well estrogenized. So there's not a lot of osteoporosis like PCOS women, right? But they're actually very vitamin deficient. So don't rely on the fact that premenopausal, they have enough estrogen because they're obese, PCOS, type 2 diabetes. You still need to treat them as if they are vitamin D deficient. I hope that answers the question.
Thank you, Dr. Osama. And I have also another question for pediatrics. And the question is related to, do we need to take a calcium for children? They need to take calcium with vitamin D?
No, absolutely not. No need at all.
Okay. Also, I received many other questions. First question is 1-alpha. Someone is asking if 1-alpha is the best. Dr. Jacob is asking about this.
Okay, so that's probably a very good question. This is the active metabolite, but why do we need it if you have a healthy kidney that allows you to hydroxylate your sunlight exposure? Yeah, the 7D cholesterol and why, if you have supplementation of weekly doses, why do you need 1-alpha? In addition, giving 1-alpha on daily basis does not allow you to really calculate the total vitamin D in the serum. And it may actually downregulate your PTH.
Okay.
So in turn, this is my theory, that if you give somebody 1-alpha, you may actually lead to a hungry bone syndrome.
Wow.
Okay? So especially people with chronic kidney disease, unless they have because the whole idea of 1-alpha is, do you need to suppress the PTH, which is high because of the secondary hyperparathyroidism. So if you actually give it a low level of PTH, then all what you're causing is a hungry bone syndrome, which may lead to osteoporosis.
Yes.
So my advice is not to use 1-alpha unless you have a good reason to do so, hyperparathyroid, or your parathyroid being removed after thyroid surgery, or you have a secondary hyperparathyroidism, but the PTH high enough to be suppressed by the 1-alpha. Otherwise, you go into, I've seen a lot of people with osteoporosis being given 125 because it's the active metabolite, but they've forgotten the higher signals of the the parathyroid hormone, which eventually will tell your body or your bone to metabolize more calcium. So as if you're stealing more calcium. So you're giving me money in this pocket, you're taking it from the other pocket. So it's a high turnover, which eventually leads to hungry bone syndrome and osteoporosis and more fractures.
Yeah.
Does that make sense?
Yeah, it doesn't make sense. It's it's very critical to use 1-alpha with the patient unless he has a valid reason to take 1-alpha.
Yeah.
And also, doctor, there is a question related to the infant and children. What is the optimum dose for infant and children as a prevention and as a treatment?
I'm not a pediatrician, but I think it's in the guidelines there. Please don't push me hard. I hardly know diabetes.
So I believe the standard dose, Dr. Osama, is 400 international unit per day for the neonates after 1 year. And after 1 year, you can go for 600 international unit. It's quite simple and it's a very easy dose for prophylaxis of pediatrics. And also there is another question about toxicity after using a high dose for a long time. So what the dose can cause a toxicity if we use it for a long time?
It's not the dose actually. It's the 50,000 per week that we worry about.
Yeah.
That's where I've seen people, and actually we have some population in UAE here in the Gulf who actually have a high level of vitamin D as this without any. But those are the fishermen. Those are the elderly population who worked before UAE when Sheikh Zayed Rahmatullah alayhi did that beautiful. People were working in the sun and fishing every day. So they had enough sun exposure. And then we came as doctors from UK and so on with our degrees. Oh, no, you're an old man, you need vitamin D. I don't need it. You come later, vitamin D 250 nanomole, whatever. It's toxicity. It's not that dangerous, but you shouldn't be actually pushing, vitamin D level very high.
So, Dr. Osama, also I got an interesting question about the role of ACE inhibitors in the current COVID-19 management.
Don't stop it.
Okay. So
just don't stop it. Don't stop it. You have to differentiate between ACE2 receptor as an extracellular and intracellular, between the one that carries the spike protein from the SARS-CoV-2 virus, okay, and between the other ACE receptors that actually involved in the ACE and RAS blockade and hypertensive medication. And you have to remember, if you stop those medications, then you're allowing a surge of hypertension, which eventually increases your mortality rate. So the current guidance is do not stop your ACE and ARB unless you have an acute kidney injury. But that's then the patient will be in intensive care.
yes.
Do not stop your ACE and ARB. Do not stop it.
Thank you, doctor. And also, doctor, there is a question about the cytokines and chemokines has a role in the triggering of the COVID-19. So the question here is immunosuppressive or vitamin D can be considered as a manner as an immunosuppressant?
I mean, vitamin D as an immunosuppressant?
This is the question, but we can tackle only the part of if the cytokines and chemokines has a role in the COVID-19 condition. So using immunosuppressant can play a role to reduce this interaction and it can be used in the treatment of COVID-19?
It will kill the patient.
Okay.
Do not use immunosuppressant.
Yes.
No, because it's a different pathway, right? Yes. Involves your cyclic MP, your interleukin-6 mediated cytokine storm. That's a different scenario. Okay. I would not use an immunosuppressant. It's used already immunosuppressed.
Yeah.
Because the pathogenesis is related to the protein in the virus itself. Okay.
Yeah.
That link to the surface of the cell by the ACE2 receptor and then activate the cascade.
Yes.
So by giving immunosuppressant, all you're doing is you hitting the wind.
More chance.
Exactly, and you suppressing the immune system and you're actually not fighting the actual problem.
Yes.
Okay.
Totally clear, doctor. And also, doctor, there is a question which is there is any correlation between the infection and vitamin D level? Can it suppress or increase the vitamin D level kind of infection?
I mean, the infection itself, I don't know, but I don't think so. If your vitamin D is sufficient by the time you come into the hospital, there's no reason that an acute lung injury, okay, will actually lower your vitamin D. Yeah. So remember, when we talk about vitamin D, guys, here, it's actually okay. We're not trying to promote it as a causal relation. It's a correlation. So between causes and linear correlation. Okay, so we don't mean that one of them cause the other. So neither an ARTI will cause vitamin D deficiency or vitamin D deficiency will cause an ARTI. It's just a correlation, not a causality. Okay, we're trying to bring the ideas together, sharing our experience and your experience to understand through those meta-analysis to why those two coexist together.
Yeah.
But we come clear. It's latitude, it's Italy, it's Japan, death rate, elderly population, level of vitamin D, mechanical ventilation, fibrosis, and so on.
Yeah. So, doctor, there is another question here related to the NIH is recommending that a high, more of level of vitamin D, more than 20 nanogram per milliliter, generally considered as adequate for bone and overall health in healthy individuals. Emergency evidence link a potential adverse effect to such a high level, particularly more than 150 nanomole per liter, which means more than 60 nanogram per milliliter. So I follow more 20 to 60 nanogram per ml going with IOM guidelines. What is your comment regarding this?
I think you just need 40 to 60 nanogram per ml. That's what you need.
Okay.
Yeah? Listen, there's no evidence on acute setting and vitamin D level. Okay? But the sufficient level for you to be healthy enough, depending on your age, is 40 to 60 nanogram per ml. That's for adults. You have certain different criteria for kids and postmenopausal women, but we accept 40 to 60 nanogram per men and women with with reasonable life expectancy to be sufficient.
Okay, I believe it's very clear, Dr. Osama, and I believe that we have many questions. I don't know, but we have a lot of questions, and I will never stop till we finish the last question, Dr. Osama, if you allow me.
Yes,
And
okay.
as per your talk, Dr. Osama, you mentioned initially for adults is 10,000 IU for a few weeks to reach to 25 nanogram. Is it allowed to take 50,000 IU initially per week? Other 10,000 international per day for 1 week. So I think it's also related to is it better to use the 50,000 or to use the 70 or to use the 10,000? So I believe that you answered the question.
Look, it doesn't matter if you're talking prevention or deficiency treatment, it's different, right?
Yes.
Look, I told you, me personally, I follow the 10,000 per week, okay, to maintain level.
Yes.
If they insufficient, okay, or deficient. So if I have somebody with borderline deficiency, I go with a 20 units per week. The people who are insufficient or severely deficient, then 50,000 per week is what I would use normally. But do not use it more than probably 8 to 12 weeks.
I believe, Dr. Osama, here the challenge with the most of the people in UAE that, as you know, in the private sector, that vitamin D test is not covered by insurance.
Excellent. Just use 20. Use your common sense. Put it this way. Let's presume that each one of us will take from food 1,000 units per day.
Yes.
Right. So that's 7,000 per week. So just stick them on 10,000 units per week, and you will be fine. As simple as this.
Okay.
If they high risk, stick them on 20,000 per week, and khalas, that's it.
Okay. So there is another question which is related that if there is any proof that vitamin D deficiency can cause obesity.
Vitamin D deficiency causing obesity.
Yes.
Listen, I'm a diabetologist. I'm not clever enough. I don't know the answer.
Okay.
If it causes depression and poor mobility, then you become fat like myself. I actually don't know the answer for this. I must admit. But certainly, vitamin D is more prevalent in obese patients.
Yes.
But I don't think it's a causal relation. You might be, listen, and the one thing I must say to you, vitamin D does not prevent cancer, neither cardiovascular disease. Just make sure that you don't get deceived by this. You know, the vital study back in 2018 presented the AHA that, no evidence that neither omega-3 or vitamin D or both of them together reduce your cancer risk or cardiovascular disease.
Yeah. Clear, Dr. Osam. So I received also one comment that thanks for amazing lecture. Should healthcare workers take a high dose state to build up immunity, even though studies suggest daily, weekly dose is better?
We all should take vitamin D.
Yes.
Whether you take 2 tablets a day or you take 10,000 per week, it's up to you. But we all must take it.
Here also another question, doctor, and I really appreciate your answer about this, because here there is a question which say that do you agree that oral vitamin D absorption is 20% only, while injectable vitamin D absorption is 80 to 90%?
By availability.
Yes.
So they're asking if vitamin D injection is much better absorption.
Yes.
Well, certainly, but it will only maintain. So you have to, talk about half-life. So if I give you one shot, right?
Yes.
You have a steep rise in your level, then it falls down. And
yes.
If I give you a smaller dose, yes, half-life is shorter, but then you get infrequent dosing.
Yes. Yes.
I only give vitamin D injection because the patient in the Gulf insists that they have it.
Yes. So I think it's in vitamin D, it's like easy come, easy go. So if you give a high, so you lose it in a very quickly manner. Yeah. And I do believe that the recommended dose from the Endocrine Society guidelines, which is a 10,000 per week, as you were saying, that guarantee to reach to a standard level or a sufficient level of vitamin D. Okay, even if the bioavailability is less in the oral than
because when you take it through the gut, you allow the hydroxylation through the liver and the kidney.
Yes, yes, correct.
You're better absorbing, it's a fat soluble. It's a fat soluble vitamin D. So
yes, yes.
It's got to be. Gosh, the questions are very hard, but I'm trying my best. Come on.
Does vitamin D capsules make any kind of abdominal discomfort?
No, not that I know of, unless you have a big chunky chalk-like tablet.
Yeah.
People prefer the gelatin oily one in general.
Yes. Yes. So still idea of giving vitamin D injection preparation dose as oral, is that true? People are asking about if it's
a valuable question. There's a good soluble component, okay, of vitamin D3.
Yeah.
Because D2 is the one you have in injection, but they have a soluble D3 preparation made in Argentina and France, and they seems to be reasonable, but you have to be taking a large amount, like 100,000 per month.
Yes.
Look, I don't know. We live in an age of easiness. People do what they like and what they read and stuff like this. If it was me, I don't know. So I might just drink an injection, a D3, because it's easier for me. I don't know. But I would certainly not, from a practitioner point of view, I'll probably say no.
Yeah.
But I might do it myself.
So my comment here, doctor, that already we have the capsule form, which is very easy to be administered. And for example, if I want to take like a 50,000, I have the 50,000 oral capsule, and if I want to take a 10,000, I have also the capsule. So why to put myself in a corner to drink the oil form of the injectable? And it would be quite difficult for people. Some people they are not comfortable with drinking such kind of oily.
And Ahmed, nowhere in the recommendation they talk about injection. I'm just trying to open the recommendation on my phone again. No, nowhere it says injectable.
Yes. So also there is a question about which form is more effective, is a vitamin D2 or a vitamin D3? Both.
Three. I would have. Unless you take in an injection, then it's D2. Okay. Yeah. So the whole idea, because look, it's the D3 that attract the liver for hydroxylation. Okay. So D3 is actually the most active component before it enters the liver and then the kidney. Okay.
Okay. So you mentioned, doctor, about in your speech about symptoms of vitamin D deficiency and GIT issue. So the person who asking the question is working as a pharmacist. So many people are complaining about GIT related issue, how it's correlated with vitamin D, if you can explain.
It depends. Look, it's a fat soluble, so it depends if you take capsule or you take a tablet. So if you take a capsule, in general, you have very little, and if you take it with food, preferably with meat, large meat, just I say to them after you food. Okay. Okay. And that should hopefully eliminate it. So
we received a question from Dr. Bashar. He is from Tawam Hospital. He's endocrinologist, and he was asking
Dr.
you
Bashar
about.
He's a very tough guy.
Yeah. So he is asking you, Dr. Osama, about what is the effect of the infection on vitamin D level and vice versa.
What? Sorry, what's the question again from Dr. Bashar?
What is the effect of infection on vitamin D levels and vice versa? What's the effect of vitamin D on the infection? What is the infection on the vitamin D?
Look, Bashar is much more experienced guy than myself, and so it will be a pleasure to talk to him. So we've shown from these meta-analysis that actually there's a correlation between low vitamin D level and the increased incidence of ARTI. Okay, and the other side, if you have sufficient enough of vitamin D level, then you're less likely to get a recurrent ARTIs. Again, and thanks Bashar for a difficult question. It's not a causal relation, it's a correlation. And if you know better than this, please let me know. He knows a lot.
Okay. So how much body parts should be exposed to the sunlight, and what is the best exposure time in UAE in order to get vitamin D from the sun?
I always ask the question, how much sun exposure you need to get vitamin D?
Yes.
It's a long, I mean, look, difficult. It's not a difficult question, but it depends on the time of the year in UAE, because the weather is very hot and people don't actually get exposed to sun quite a lot here. Yeah. I would say to people, probably the best time to be exposed to light is probably between 9 and 11 and between probably 4 and 6 in general, okay, if they're going to be exposed to light. Again, you don't want to be people exposed to light for a long time, okay, but probably 15 to 30 minutes per day, it should be enough to get you around probably 800 units. Again, it depends on your skin texture, on when you are, where you are, okay, and whether you actually have any other comorbidities or medical background.
Okay. So another question also, we should, and this question related to the CKD patient and patient with renal failure. And the question is, do we need to give both vitamin D3 and 1-alpha for patient with renal failure or no?
Probably, if you, that's a very good question, because here we're talking about, the lack of hydration in the kidney. So all depends on your parathyroid level, on PTH. Yeah. So it depends on your total serum vitamin D and your PTH. So if you have a high PTH, you're better off doing 1-alpha first.
Yeah.
Okay. But if you have normal PTH, only normal, around 10, 11, so you don't have a rise in PTH and vitamin D, low vitamin D, then a small supplementation of 10,000 per week is probably a better option.
Okay, so Dr. Osama, you believe that people on 1-alpha, they need to be regularly tested for PTH. This is the only way out.
I think look, it's for me, I will not start anybody on 1-alpha unless I have a PTH level.
Okay.
And you have there's many reasons why we use 1-alpha, but you have the calcium, the PTH, and the phosphor level as well, right? So you cannot just give 1-alpha, otherwise you would cause a hungry bone syndrome.
Okay. So Dr. Osama, also, do you know if there is any role of the biological treatment in COVID-19?
Any role of what? Sorry?
Of biological treatment, the infliximab and the other kind of biological treatment in COVID-19.
There's a lot. I can't remember all of them now, but certainly there's a lot of biological treatment. Certainly, there was one in France, in China, and the States. But I'm top of my head, I can't remember all of them now.
Okay. So also there is a question about dark-skinned children. Do they need a high dose of vitamin D for prevention? Yes or no?
It depends on the vitamin D level as well.
I totally agree with you, and yes, I believe also that any person with a dark skin, because of the too much presence of melatonin, that doesn't give a sufficient chance for the sun to do the proper metabolism.
We have this wrong impression of they have enough vitamin D. You need to check the vitamin D, and for children, you have to treat them exactly the same.
Yes. So I get a lot of comments about thanks to you, Dr. Osama. A lot of thank you to you, and no, it doesn't cause obesity. No, disagree of vital study. I think we almost finished. Is it safe to take a vitamin D? It's endless for patient when you say it is enough. Someone say that, is it an endless process to give a patient a vitamin D as a treatment and prevention, or there is a point when you decide to stop patient on vitamin D?
Well, that's very good. If you're at risk of vitamin D deficiency and vitamin D deficiency complication, like osteoporosis, osteomalacia, and so on, and recurrent URTI and influenza and so on, then you should carry on. Yeah, if you're not at risk and you achieve the level and you have no other concerns about the patient and they have enough sun exposure, then probably you shouldn't. Yeah.
Yes.
But we're talking about the population because we've seen the pandemic recently. We're talking about the population who are at risk: elderly, obese, type 2, cardiovascular, heart failure, COPD, and so on.
Yes.
Yeah.
I believe we finished, Dr. Osama, all the questions. I know it was a long journey with many questions from many people. That means that people enjoyed your presentation and there was a lot of valuable information. I would like to thank you very much for your presence with us today. I would like to thank all the people who attend. We have a great attendance of 500 participants. So I would like to thank all of the presents for the event, and I wish that we covered all the information related to COVID-19 and vitamin D. So thank you for all, and it's a great thank you from Euro-Pharm and Euro-D and D40 and BDVD for all the people who attend. So wish you all the best, and I hope that we will have a lot of coming event and a lot of coming information related to medications that can help a lot of patients who are suffering from COVID-19, or to cover also the other medical field. Thank you to Osama again, and thank you everyone. So wish you a great night.
Thank you. Happy Ramadan and Eid. Thank you very much.
Happy Ramadan and Eid for you, doctor. Thank you. Take care, Dr. Sam. Thank you.